Thank you.
Thanks, Caitlin. So first of all, welcome. It's great to see everybody here tonight on what has turned out to be a bit of a blustery, windy evening. But again, welcome everybody on behalf of the Faculty of Health to tonight's 2025 Hallman Lecture, Health and Happiness, Prescribing Beyond Medicine. My name is Steve Fisher, and I'm really delighted to welcome you here to Waterloo today. So I want to start with a territorial acknowledgement. As we gather here today, I want to begin by acknowledging that much of our work takes place in the traditional territory of the Haudenosaunee, Anishinaabe, and Neutral peoples. Our main campus is situated on the Haldeman Tract, land that is promised to the Six Nations of the Grand River and extends 6 miles on each side of the river. This acknowledgement, I think, is really important, and it reminds us that our work, our learning, our conversations take place within a broader context. By pausing, we have an opportunity to reflect on what it means to live, learn, and do research in a way that acknowledges Indigenous ways of knowing and being, and to think about how ideas that we'll talk more about tonight, like community, connection, and collective well-being matter. I reflect a little bit on some of the words from our Indigenous knowledge keeper, Elder Henry, who spoke recently at Convocation, shares a number of stories, and most of those stories celebrate that sense of connection and community and purpose. So I think it's really important that we acknowledge and recognize that here today. Again, welcome to this Hallman Lecture. We're really excited to have the support of the Hallman Foundation to support this series, and it's long been a space where we can talk about big ideas and connect those big ideas with human stories. We ask not just what keeps us healthy, but how you can create conditions that everybody lives well. I'm really looking forward to our panel's discussion on that today. The series was established through the generous support of the Wild S. Hallman Foundation, whose commitment to improving community health, quality of life, continues to inspire much of what we do here at Waterloo. The Hallman legacy reminds us that the pursuit of health is not solely a scientific or medical challenge, it's a social challenge. It calls for collaboration across sectors, compassion, and innovation, not just in technology, which we're pretty good at Waterloo, we spend a lot of time focusing on that, but also innovation in policy, innovation in design, so thinking bigger about what innovation means for us. Tonight's theme, Health and Happiness, Prescribing Beyond Medicine, embodies this spirit perfectly. It invites us to look beyond traditional health systems to the social and environmental factors that shape our everyday lives. It asks us to see health as more than an absence of illness. It's also about belonging, purpose, joy, happiness, which we'll talk about tonight, and equity. Those ideas feel especially timely as we collectively rethink what well-being means in our workplaces, our cities, and our social networks. I'm really excited to be here today and on behalf of the faculty, and in addition to the wonderful panel, is to announce to everybody here a really exciting initiative that's currently underway at Waterloo, which we're calling the Healthy Waterloo Initiative. At Waterloo, this kind of thinking is really coming to life through the Healthy Waterloo Initiative, which is a collaborative effort to make our university, and by extension our broader community, and ultimately our country, the healthiest in the world. Easy goal, we should be there by next week. What I want to remind folks, and what we're really excited about here, is that Healthy Waterloo isn't a single project. It's not a single program. It's a movement. It's a call to action to reimagine the university as a living lab where research, policy, and practice come together to improve lives. We're working across disciplines, public health, engineering, recreation, architecture, business, and beyond. And we're asking questions like, how can data and design help us create environments where people can thrive? How can we better understand the links between mental, physical, and social well-being? How can we partner with organizations, municipalities, and citizens to turn this knowledge into action? So our vision is a future where health is woven into the everyday fabric of how we live, study, and work. It doesn't wait for the hospital door. For example, imagine a campus where spaces encourage movement and connection, where social prescribing is part of student support, and where innovations developed right here ripple outwards to influence communities across Waterloo region and beyond. Healthy Waterloo is grounded in the belief that health is a shared responsibility It grows stronger when we work together, when universities, health systems, and communities act as partners in creating the conditions for well-being. And that's exactly what tonight's discussion is about. Each of our panelists brings a unique lens, clinical, policy, psychological, yet all share a commitment to rethinking how we define and prescribe health in ways that extend beyond medicine. So as we listen this evening, I encourage you to think about the possibilities. What might it look like if social connection were as central to public health as vaccines or blood pressure screens? What if we could measure meaning and belonging as rigorously as we do cholesterol levels? Those are the kinds of questions that inspire Healthy Waterloo, and I hope they'll inspire you too. Thank you for joining us, for lending your attention and your ideas to this conversation, and for helping us move forward toward a future where health and happiness are truly shared outcomes. It's now my pleasure to invite Dr. Troy Glover to introduce our distinguished panelists.
Bear with me, sorry. Okay, can everybody hear me okay? Yep. Excellent. I'm not sure it was so healthy, me driving here tonight. I came from a meeting that ended at 5:30 and somehow made it almost on time. So I'm impressed with myself that I did so. Thank you for being here today. We have a really exciting panel discussion related to prescribing beyond medicine, health and happiness. And so I'm delighted to introduce our three esteemed panelists. To begin, we have Dr. Kate Mulligan. Dr. Kate Mulligan is the Canadian Commonwealth Fund Harkness Fellow in Healthcare Policy and Practice at the City College of New York. And she's also an associate professor in public health at the University of Toronto. She is also the founding scientific director of the Canadian Institute for Social Prescribing. In addition, we have Dr. Felix Cheung. Dr. Cheung is an assistant professor and Canada Research Chair in Population Wellbeing at the University of Toronto and a leading scholar on happiness and well-being. He directs the Population Wellbeing Lab and also serves on the World Wellbeing Panel. And finally, we have Dr. Gary Block. Dr. Block is a family physician with St. Michael's Hospital and Inner City Health Associates. And he's also an associate professor at the University of Toronto. He has led an innovative clinical program, developed educational curricula, and served on an Ontario government task force addressing income security. Now, before we get into questions, I thought it would be helpful to have each panelist introduce themselves beyond their titles. So perhaps we can start with Dr. Cheung.
Hello. Oh, that works. Great. My name is Felix is Latin for happiness, and also do happiness research, so that's convenient. So beyond the introduction, my research group also releases the Canadian Happiness Report, where we, based on large-scale survey data from Canadians, try to document the latest trends and distribution of happiness across Canada. Our latest report in 2024 looked at the overtime trend in youth well-being. And based on data from over thousands of Canadians, we found that Canadian happiness has been dropping in the past 10 years, and especially concentrated among youth. Another effort that I'm a part of is the World Happiness Report. It's released every March 20th because it's the International Day of Happiness. It's also the only day the world finally pay attention to my research area. If you have seen that, we usually release the National Happiness Ranking. In case you have seen how, Finland is the happiest country in the world, that's the World Happiness Report. So this year, it's actually very relevant to the theme tonight. This year's World Happiness Report is about sharing and caring. So, there are probably questions where I can go into a little bit more about what we put into the report. So maybe I will just pause there for now. So my main work is about studying, population level determinants, consequences of well-being, and also do this type of Canadian employment.
All right, thank you. Dr. Mulligan.
Okay, call me Kate, please. Felix's name means happiness. My last name, Mulligan, means, well, if you know anything about golf, if you have a really bad you can take another one for free. That's about from my great-great-uncle David. So my work is really about if at first you don't succeed, just try again. Really that's what I do. So I work on social prescribing, which is, for me, about community scale, neighborhood scale health leadership. And using the health system as one entry point to help support people to connect to the things that we know really determine their health. So upwards of 80% of our health outcomes are determined by things in our homes, in our communities, and also in our relationships. So I'm a health geographer by training, and I'm very interested in health as not just the presence or absence of disease or well-being, but as something that happens in the most literal way possible in relationships. We breathe. We are always in exchange with our environments, right? Our bodies are working toward homeostasis. We're in relationships with other people, with the land around us, with our histories and cultures, with our sense of self, and so on. And so it's in that relationship where health happens. For me, in a dynamic way. If we don't have that, we're not alive. And so social prescribing is a way to build better relationships in our lives, but also between healthcare and other services and other programs and other community strengths that are out there, and to build better connections that really recognize and respect and resource things like household labor, caregiving work, community organizations, parks, right? All of those kinds of things that we know are supporting our health and well-being. On a personal level, I have 3 kids, 2 cats, and 1 husband. And one of my kids has been through a lot of health issues in the last year and a half, and really has benefited from that integration of acute clinical care and social and community care. And so we've, and as a caregiver, as a family, we have also benefited from this. So we've experienced this in our lives. And I'll just to give one embarrassing shout out. Today is Take Your Kids to Work Day for the grade 9s. My daughter Aoife is somewhere in this room, so thank you Aoife for being here.
Excellent, sorry about
And hi Aoife. Well, first of all, I'm Gary. I actually have no idea what Gary means. I'm convinced I was named after a South African golfer, Gary Player. My parents would not have you can ask them, they're sitting right over here. So we'll see. So I spend most of my life as a family physician. So I work on the front lines of family medicine with St. Michael's Hospital downtown Toronto, also with that group called Intercity Health Associates that provides services to people experiencing homelessness across the Greater Toronto area. But the reason I'm here and sort of my passion is really around thinking about ways that we can convince the health system and frontline health providers, especially primary care providers, to deal with not just physical health and not just mental health, but also people's social health, meaning sort of bringing in an understanding of the social conditions in which people live into our realm of understanding what health means, but also our realm of action. And I've been doing that for a long time. I've been doing that for really as long as I've been in practice, which is 20 years now. Over that time, and I'll say that, I sort of think about kind of 2 levels of social risks to health. There's probably many ways you can conceptualize it of this. One of them is sort of what I think of as sort of more material or kind of tangible determinants of health. These are things like income and housing and education. And I've been involved in developing a bunch of programs within our team to deal with those issues specifically. Like having full-time income support specialists, or programs that focus on literacy or access to justice and lawyers. The other level is sort of pushing that into thinking about structural what we often call structural determinants of health, right? Like big underlying social forces, that are really sort of built into the structures of our society and ourselves, things like racism and colonialism and capitalism and, homophobia, transphobia, etc. These really big drivers that in many ways determine who is most impacted by those other social determinants of health. And we've also done a lot of work to build programs around those, right? Like we spent the last 8 years thinking about how to address racism in our team, for example. We spent the last 5 or 6 years deeply diving into what it means to decolonize our team or to build culturally safe spaces for Indigenous staff and Indigenous patients. More recently dealing with things like ableism in a very deep way. And I'm telling you this, I'm kind of summarizing 2 decades of work here in about 3.5 minutes. Partly because I want to get to the latest piece of the story, which is that over the last couple of years, we've been very fortunate to be able to build something that we now call the social prescribing program. Although I would argue that all of that probably fits within the umbrella of social prescribing. But because I think the world is starting to, our health world is starting to take notice of this idea of social prescribing, there's kind of funding flowing into this in a really significant way, we're now able to push deeper into what it means to address these types of issues on the front lines of care. And what that means for us in the program we're building out right now is, first of all, a different kind of individual support program. In our case, it's for older adults within our community. It's an individual support program that relies on workers that come from within the communities that we work with. So with what we sometimes call link workers or community health workers. It also relies on a very deep relationship-based approach to understanding people's social context and really their social stories in a far deeper way than we were doing when, all we were focusing on, for example, was someone's income, or someone's ability to access a particular social service. This is a far more holistic approach. But the other side of this program is that we're able to actually start to look at the communities we work with as entities within themselves, right? So we're actually starting to address not just individual health, but community health, population health, in a way that is not really normal for a kind of traditional primary care team like ours. And what that means is really about building relationships with community organizations, community leaders, other partners within the community. It's also about thinking about how can we support community development, community empowerment, how do we, including things like transferring our resources directly into community in various ways. We can talk about that a little bit later. But this is really interesting new territory for us. And again, I guess we'll get into this in the conversation, but just to kind of offer 3 sort of conceptual foundations from which I work, I'd say one of them is really about sort of pushing our thinking of health upstream. So kind of taking our program development approach, or approaching program development from this idea that the farther upstream we go, the more we're dealing with kind of fundamental social foundations of health, the bigger the impact we're going to have downstream. So on people's individual health, that shouldn't be new to people. I'd say second of all, it's really about designing programs for those who are most marginalized socially. And this is something we're really trying to build into what we do, that we kind of start from the outside and social margins and then kind of allow that to work its way in. And third of all, that this is really about shifting power. And I think that's a lot of what underlies this kind of latest wave of development of these programs that looks at individual empowerment and community empowerment from a real kind of deep analysis of where power sits in the communities and society that we work in. So I'll leave it there.
Excellent. Well, it's a pleasure to have you 3 here with us today. I'm going to get the questions started, so I'll have a few questions for the panelists. We'll get their responses, and then we'll open it up to the audience for your questions as well. This isn't a long event, so we only have an hour, and we're I guess, at least a third of the way through, so we'll try to be a bit efficient with our questioning. But let's begin by focusing on the public discourse of health. It strikes me that it tends to emphasize individual responsibility. When we think about things like diet and exercise and self-care, what are we missing when we focus so heavily on the individual? And how might shifting to a collective or systematic lens fundamentally change how we think about health and happiness? So I'll open it up to the panel.
Okay, Troy, I'm going to say something that might be a bit provocative.
That's why you're here.
I'm a geographer, so I'm really interested in multiple levels of action, multiple scales of action. And I get this a lot from people, especially in public health, that the individual is somehow lesser than the collective, or the big P policy work alone, which I've been doing for my whole career, is superior to individual relationships. But my own experience and my own research shows you can't do good big P policy without knowing what's happening in people's relationships and in their lives. And that we need that multi-scalar action. And so that's why I often, I know that the term upstream is like a convenient shorthand for, broader determinants, but health doesn't happen in a linear way, right? So we're not talking about different parts along the line or a continuum, right? It's happening in all kinds of very complex ways. And it's those relationships over time, but also over space and across different types of relationships that really matter. And my experience has been that we tend to focus on the systems, the structures, the resources and policy flows a lot in practice. And we tend to focus on mental models a lot in academia or in the arts. Right? We just change your paradigm, everything will be fine, right? But we don't focus on the middle relational layer, developing connections between one another, thinking about power dynamics. And so we really need all of those components in order to make change and to learn from practice. And so one thing that I love about social prescribing is it's a way that we can help people change practice without having to first change their hearts and minds. So we can give a tool that will help address the determinants of health in a very concrete way, and people will learn for themselves through the feedback that happens, the measurement, the tracking, the deep relationship building, what's working well and what needs to be changed, and so on. And then that opens people up to the paradigm shift or the broader change or the bigger P policy stuff. And so I've been spending the last 5 or more years supporting people who are doing those steps locally, figuring it out, and just continuing to support and elevate and amplify really good work where it's happening, and bring it to the attention of policy and decision makers and funders so that they get the sense something's happening here. I was speaking with folks from the Department of Canadian Heritage, and they said, we keep hearing that Canada's a leader in social prescribing, but we are not leading the social prescribing. And they were very puzzled that the leadership could happen from somewhere other than within that government. And so I love that. I love that the leadership is happening, locally in community. There's tons of people in this room right now who are leading this work in policy, in practice, in research, and so on. And that is great. And so we want to think in a more complex adaptive systems way about how system change really happens. And so, yes, we do want to get to those broad enablers, but things like social prescribing can help us do precision community health to measure and track exactly, not just in a sort of general population sense, but in a very specific sense, what happens to people's health experiences, health outcomes, and use of health services when they are referred to these kinds of things. And then where are the referrals going? Where is their need in a very specific way for more investment, better support and infrastructure, and so on. And so that we can build the argument that, something I've been saying to Canadian government lately, which is for every physical hard infrastructure investment that you're making, you need to have a paired social infrastructure investment in relationships, in community supports, in parks, in libraries, in health. And so the practice is what's going to help get us there.
Yeah, it's okay framing this as a controversial take. Sometimes when you sign up to be a panelist, you don't don't know what to expect. Like, is it a more competitive one? I ended up just feeling we ended up feeling like we're on the same page. I think sometimes when I go to psychology conferences, I am the only person there where I'm trying to argue for a structural lens. Because typically when people are thinking about what the good life is, how to live a life of happiness, their mind go to the wellness industry. They think about mindfulness, meditation, and all those things are great and amazing, and they definitely have a good portion of people. And I'm like the only person, just keep beating that thought, saying that no, we also have to think about structural dimensions. So I think I'm actually just for the most part agreeing with Kate. Maybe I will just put this into a quote from my mother tongue that I feel is a little more quotable, maybe it's a little bit more memorable. So it goes something along the line of a good doctor treats a disease, a better doctor treats a person, and the best doctor treats a nation. Maybe that kind of go for a slightly different vibe because I do agree with you that like ultimately we need everyone and everything at all levels. But sometimes that's a good way to remind us that even for going beyond, like maybe parallels to health, when we're thinking about what a happy life is, it's also not just an individual pursuit, it's also a collective pursuit. Whenever I talk about the Canadian Happiness Report, sometimes I would bring up this idea that Canadian happiness has been dropping, and there are audience members who share with me that they were worried that there's something wrong with them, but hearing that there's something that's going on for us as a collective is almost liberating. On one hand, to know that it's not something that's wrong with them, but to also know that to change that, you need all of us, you need us as a collective happy. So maybe I don't want to take up too much time, but I will just say that everything Kate said applied to happiness as well.
Do you want me to answer?
Yeah, sure.
I'll just say the question is very interesting to me, partly because I come from a professional background that is hyper-focused on individuals, right? It's not even just focused on individuals, as I think everyone here probably knows. It is focused on parts of individuals, right? So it's like right down to the micro level, and so I was trained to, deal with the whatever it is, the appendix of that vibe or whatever. So what I often, and so a lot of the work that I do is really about trying to shift the sort of perspective and mindset of physicians especially, not health providers in general, but physicians especially, to get them to see the kind of interrelationships that I think both Felix and Kate are talking about. And I think the shift is actually quite simple for health providers to do, right? I mean, I think it literally sits in front of them every day, right? And it's there. It comes quite simply from allowing yourself space and time to listen to the stories of the people that sit in front of us. And that's, really when people ask me, where my work comes from, that's really what I point to, right? Is kind of the privileged access to people's, to not just people's stories, but the sort of depth of understanding of people's stories that I get from knowing people over a long period of time as a family physician, years and decades. Also that I get from being able to sit with people who've been in very marginalized situations, and have come to experience homelessness, and then I have the privilege of often having an hour or two to sit with people and really try and understand what it is that has brought them to that place, right? And those stories, they're all different. Every single one is different, but inevitably they involve a web of relationships and interactions with social structures, with other people, with communities, with individuals, obviously which are frayed in many situations, but a lot of it then turns to how we can sort of, what we can build on, what we can pull on, those relationships that haven't deteriorated, and how we can sort of start to reconnect with communities and start to see people as part of communities and part of society, and sort of rebuild an understanding of health and well-being that integrates people back into those networks. So engaging in health from that perspective inevitably pulls you there's just no way to see beyond that from my experience. Not every health provider gets that yet, but I'm gonna try.
Well, let me ask you, health systems are very good at measuring metrics like hospital visits or blood pressure. They're less good at measuring things like social cohesion, meaning, or happiness. What do you think it takes to make these less tangible dimensions of health visible and valued from a policy and practice standpoint?
Sure, I think this. Maybe let me start with how we measure happiness. Both the Canadian Happiness Report and the World Happiness Report. It goes something like, say 0 is your worst possible life, 10 is your best possible life. Where do you see yourself? You don't have to answer me right now. But for the most part, most people can come up with a number within just 15 seconds or so. And turn out this number is extremely powerful for several reasons. First, say you answer 5 this year, but next year when I see you, you answer an 8. It's a good chance that something could happen to you. So yes, we don't have a ruler to exactly measure how many units of happiness you have. But still, this is a really, really good metric to know how your life is going. There are also a large body of research talking about how, again, the single number turned out to be a very powerful predictor of all sorts of outcomes. My own research has shown that in neighborhoods where happiness has been dropping, people are much more likely to vote for the non-incumbent party, for example. And one of another colleague in this research area have in fact found that happiness metric can be a stronger predictor of election outcome. So, I don't want to paint, politicians as, just trying to extend their tenure. I'd like to think that, the government care about well-being, but that just give them endless reasons to care about people's well-being. There are also research done by myself and others that have found that happier people are healthier people. In one study where we have tracked over 10,000 people over 7 years, we found that people who have greater life satisfaction also see greatest improvement in physical well-being, social well-being, mental well-being 7 years later. And in fact, based on our bioinformatics model, it's one of the only 3 predictors of 200 predictors that we search for that can simultaneously predict better physical, mental, and social well-being. So I guess my long story short is that, when we're reflecting on this measure, we felt like, yeah, if I go from a 5 to an 8 next year, there's a good chance that my life get better. And that, even though, again, like we don't have a ruler exactly, we don't have a scale for happiness, it seems like it's very predictive of all sorts of other things that we care about.
I'll add that I've been working a lot on evaluating not just social prescribing, but also other kinds of community health interventions. And the same ethos that underpins social prescribing really works when it comes to evaluating this kind of stuff and thinking about measurement. And it's this: let's not focus so much on what's the matter with us, but on what matters to us. And that means we're creating policy and practice loops that bring the interest holders together to talk about measurement and evaluation early and often. So the decision makers and funders, the providers and implementers, the community members and participants, and so on, come together and ask what matters to us. What is the outcome that matters? Let's not assume we know what government wants to hear. It might be different from what we think. Let's ask them, right? And so, and likewise, what's important to people who are participating. So that policy and practice loop is really important. And so with Healthcare Excellence Canada, which works with lots of community health innovators across the country, I've helped to create something that I call a community health GPS, which just tells you, instead of worrying about every tiny little indicator that might tell you something about how we're doing, what are some of the big, broad directions? What's a vector that gives us magnitude and direction on things that are important? One of them, as Gary mentioned, are we supporting people to take leadership in their own health and well-being, right? That's health promotion 101. Better self-determination for people. So are they in the driver's seat? Are they focused on what matters? And are we supporting them to take action on what matters? 2, are we transferring power to community? Are we, sharing health resources with community organizations? hiring local people as community health workers, breaking down barriers, building better relationships between healthcare and social care. That's another one. And then the other one, in addition to those learning loops, is, what's the other one? Well, the public systems, right? So we still are telling governments and health systems and others how we're doing on things that will always matter to them around accountability, right? Are we being efficient with money? Are we improving health equity? And are we making life a little bit easier and happier for healthcare providers who are very burnt out and stressed right now? All of those kinds of measures still matter a lot too. So if we're thinking about empowerment, agency really of people and communities, traditional metrics, but mostly focusing on together deciding what matters, we can really cut through a lot of the noise that overwhelm that many community organizations feel, but also overwhelmed health systems feel in thinking about what are we supposed to track and how do we know what's important and how do we figure out all this data. Often it can be something much simpler where we all just decide together, here's what we're going to use as one measure that stands in for, this or that kind of broad outcome. And that's usually all policy and decision makers will read or think about anyway, right? They want to have a one-pager that tells us, are we more or less moving in the right direction for the right people on a given issue?
I see you batting third in the lineup here. That's great. I'm clean up so much. It's great. I think what I'll say about evaluation is, I never consider myself a researcher. I've been pulled into many attempts to kind of evaluate what it is that we do. I love it when there are brilliant researchers that can find ways to sort of quantify the kinds of things that we're looking at. I have found that very difficult in my setting. I've involved everything from randomized controlled trials to whatever, administrative data collection efforts to traditional qualitative research, etc. I'd say that the evaluation that I was involved in that sort of drew in the most, that generated the most excitement, I guess, amongst both the communities we work with and also the kind of groups of providers we work with, was a photo-based evaluation that we ran a couple of years ago, just as we were getting into this new social prescribing project. And this was an approach that involved literally giving cameras to older adults in St. Jamestown, so one of the communities that we work with a series of questions that really centered around how do you define health? What in your community sort of promotes well-being? And what came out of that was just this incredible match of art and stories that gave a sense of what well-being means to the people that we're working with in a way that I think would be very hard to capture quantitatively, right? In fact, I think it would be impossible, right? And these were things like, for example, somebody took a picture of the view over the city from their 27th floor apartment, tiny little apartment, but from the balcony and said, this is what I wake up to every morning and this is what makes me feel excited to get up in the day, right? Or someone else who took a picture of a tiny little dog park that just runs along a concrete wall in St. Jamestown and said, this is where I go to meet people, right? This is when I come out and it's like 3 steps from the door of her apartment building. And again, it's the ability to kind of engage with that level of complexity that I actually think gets us closer to really understanding what well-being means from the ground up in the context that I work in.
Yeah, I think that's beautiful. I want to just share another way that psychologists have tried to make some of this more tangible. I will promise I will make this brief. But in this year's World Happiness Report, we review a lot of the literature on a particular research design for this kind of fun for this question, where occasionally psychologists would go around the city, dropping wallets everywhere, and see how many wallets get returned. It's basically a measure of social connectedness or social trust in a community. Maybe it would be fun to do it here. Like if you drop your wallet in Waterloo, how many of you think that it will be returned back to you?
It's half.
I would say a good third to half of you raise your hands. So there was an actual survey done in Toronto good representative sample of Torontonians asking them the same question. 23% of Torontonians believe that if they drop a wallet, it will be returned. Okay, and then the group of psychologists come in and drop wallets everywhere. And they found that 80% of the wallets were so this is a finding. There's quality empathy gap. Sometimes our perception and the reality differs. So yes, we can talk about huge policies, huge social programs, but maybe one thing that we're going to start doing is simply look at you. People around you are trustworthy. They want to help you. People, we don't give our neighbor as much credit as they deserve. They're like very trustworthy, helpful people.
Okay, I'm sensitive about the time, and I know that I've been to many of these events, and I've always wanted to ask a question and never had the time to do so. So I'm going to open it up to the audience now, if anybody would like to ask a question. If not, I can fill that time pretty easily. But I'll invite any member of our audience to ask a question. Yes, up there.
Hi there. Thank you so much for being here. So my name is Zelda. I'm actually an undergrad in the Faculty of Environment, Geography, following in Dr. Mulligan's footsteps. You mentioned what matters to us. I know on campus, as a mature student coming back, social connectedness is taken in very different aspects, and there's an epidemic around loneliness, and so I'm just wondering how that's impacting your research, your evaluation, or where that's coming from.
Well, it used to be a tough sell to talk to people about loneliness as a determinant of health, or social connection and cohesion as determinants of health. And then we all experienced the public health measures during the COVID-19 pandemic and learned this for ourselves. And now it's very easy to talk about, and it's really gained lots of attention globally. We know that, yeah, social connections and relationships matter a whole lot. When it comes to things like social prescribing, I still like to really focus on what's strong with us over what's wrong with us. And so when it comes to things like on campus, social prescribing, I've been working with one of my postdoctoral fellows for a while on this. We are trying to build on the strengths that students and their communities and campus communities have already. There are tons of resources on campus. We need to help people connect to them better and in more consistent ways. And our research has really shown that asking students what matters to them has helped us understand how to connect them better. So students at the University of Toronto, where we've done some research, said really they're focused on their studies. That's what matters to them, and they've dropped a lot of the other things that are healthy, they know are good for them in their lives, including social connection and friendships, because they're focused on working, surviving life, and getting good grades. So we're now thinking about incorporating social prescribing assignments into coursework, even if it's not about social prescribing. Maybe in your coursework in math or in biology or anything, to require you to do some of these things that connect with other people, connect with healthy things, movement, physical activity, time in nature, time with other people. That's what's motivating students right now. So we have to meet people where they are, and that includes everyone from the clinicians who want to hear things in clinical language to students who want to know how this is going to help their bottom line, which is grades and graduation. So those are some of the ways that we're thinking about tailoring social prescribing on campus.
Yeah, I wonder if that's a reflection of our larger society and its goals or its ambitions around what they view as outcomes that they value. Because as I was listening to all of you speak, I'm on board completely. But when I think about happiness, or I think about I think often that's viewed as something that might be an alternative to measuring GDP when we look at our country, and yet we can pay lip service to that, or even social connectedness, but ultimately, are people valuing other things over that, and how do we, as a collective group, promote the importance of social connectedness and happiness, and how they should be valued more by individuals and groups and communities. I don't know, what are your thoughts?
So, go ahead. I'll just say one thing. We have done some research that shows for every $1 invested in social prescribing, we see a $4.43 social return on investment in terms of decreased healthcare costs, but also increased social and economic participation. So we can speak that language all day long if it's helpful. It's actually not that meaningful. I think it's good. It's one of those that everybody wants the policy, the economic argument. It's good to have, but it's not the thing that's really going to change minds. It's going to be like what's going to get votes, what people really do care about. We face a lot of pressures in our lives, like in my own life. I'm a parent. I am a working person. Like, how am I supposed to find time to do knitting? I know it's good for me, but like it's hard, right? So our society, like as Gary said with the upstream stuff, it's not structured to make it easy. So let's think about ways that do make it easier by tailoring it into what we already do value and care about. And yeah, what we value and care about is often like it's gendered, it's racialized. A lot of the work that we're talking about here is, that domestic community labor that is devalued for all kinds of reasons. But if we can help to speak the language of clinical medicine, economics, and so on, then okay, maybe we're building legitimacy for it in that way. But also hopefully just tailoring it into our lives in ways that we think are equitable and sustainable for us.
Yeah, I think all I want to ask, and also sort of thinking right back to your question, it's a really good one. Like, a lot of this to me, and especially in the spaces that I work, which are really kind of direct interactional spaces, it's about sort of breaking down the walls of what we can talk about, what we can ask about, what we can think about. I think back to medical school when everyone was so afraid to ask about sexual orientation, right? Oh my God, how are we gonna ask this question, right? Those walls kind of came down. Then I started into some anti-poverty stuff, and everyone said to me, you cannot ask people about their income, right? And I was like, well, okay, but let's see. And it turned out you could, and people were quite happy to discuss the realities of not having enough money to survive. And then more recently, I think a very similar thing is happening around loneliness, right? Now, I had the same reaction a few years ago when this was brought forward. I was like, I can't ask people if they're lonely. That's just way too intimate and personal and pointed. It's going to devastate people, right? How can they possibly deal with that? And similar to those other experiences, what I found with this is like, you ask the question, people open up, right? And like to a person, people are willing to talk about their experiences of isolation and of loneliness, right? And it was a surprise to me, truly. But I still haven't found anyone that I've interacted with around this who has just like shied away from that question. And in fact, people are happy to be asked it. They appreciate being offered the chance to talk about what this means in their context, being isolated or feeling lonely, right? So I'm hoping these walls truly are coming down around this one as well.
I really love that, and it reminds me too that one reason why we haven't had as much social prescribing is that a lot of clinicians don't want to ask if they're not sure what to do with the answer. And Gary in his work has shown huge courage and leadership in figuring that out and being willing to ask and figure out how to get to an answer even if he doesn't already have one. That is very rare and very leaderful to really be doing that. And the other thing I wanted to mention, before I forget, some research that I did with a little park called the Bentway in Toronto. Asking people what would make them feel socially connected and healthy in that little space. And it came down to just only two really simple things. And I hope this is part of what you remember from tonight. An invitation and a place to sit. So a conversation around social connection and loneliness or your level of happiness or some of these other things is an invitation to that conversation and a place to sit, like creating some actual space for the time, the relationship, the thinking, the figuring out together what to do next. All of those things really matter, and they do require us to slow down a little bit. And when the clinicians don't have time because they're under such pressure, we have these community health workers whose mandate it is to create even more time and space for them.
Another question over here? No? Yep.
We're very connected there, weren't we? So I think we're all here, I would suspect that we're all here because we believe in this, and hopefully all of us feel that we have an ability to be able to influence as well. So what I'm curious about I support practice facilitators in primary care in a different province who are trying to help to change physician behavior. So my question in particular is to Dr. Block around, let's say we're trying to influence our own physician, or we're in a position to be able to try to influence. And you've talked a lot about transfer of control, you've talked about time to learn about patients. If we're trying to help to influence that behavior, what would your best advice be? And then I think that I would also like to hear from the others how we can influence in other areas that you're involved in as well, because I think this may be where a lot of the power may come from.
Yeah, I mean, it's a complex story, and a lot of this doesn't happen in one-on-one relationships with physicians, although I think that things can be offered to individual physicians that may help, right? The first piece that comes to mind, and this points, I think, directly to what Kate was getting at, which is really about sort of breaking open this idea of what is possible, what can be done through a healthcare setting. And a large part of that is just kind of showing clinicians what is actually there at their fingertips, right? So when we set into this social prescribing work, the first thing we did actually was build a map of resources in our local community, right? And we have a very rich local community. I mean, there's a ton, like, rich in terms of resources and community supports. There's a ton going on there, and for someone who's worked there for 2 decades, like, the number of things that I learned about that I hadn't heard of before was kind of shocking, right, and sad, right? A little bit disturbing, because I was like, oh, how could there have been so many walls between my world and what's going on in the community that I didn't see this? And so to be able to even just step into a clinician's office and just sort of say, you know what, have you heard of this space or this space or this space or these people who are trying to serve this need in this way, and here's how you can refer into them, is probably the first step I would take, right? I think that is a kind of empowering approach to a clinician. Generally, most frontline clinicians these days will say they feel overwhelmed, distressed, et cetera, et cetera. And I think what we need to do is sort of just open up realms of possibility for them and offer them more, and offer them ways to address issues that they didn't feel like they could address. I will say, I mean, there is evidence that putting programs in place that address social risks to health improve provider wellness, health provider wellness, right? And that kind of data is very useful in approaching clinicians, because their first reaction generally to me coming in and saying, you need to build a new program focused in this area that you've never dealt with, their first reaction is generally not a chance, right? There's no way I'm adding something on to my already overloaded plate. So, what I offer there is to say, well, you know what, you're struggling to deal with this area anyways, you just haven't known what to do about it, and you often just push it under the table, but it's there as a tension between you and your patients, and you and your sense of whether you are able to really address patients' needs. So you're going to feel better. That's, I can almost guarantee that. So these are the kinds of things that I do.
We have only 5 minutes left, so we can pass on to the other panelists for a response, but if you could keep it fairly succinct.
Okay, I spend a lot of my time thinking about how to influence, and I'll just say people like to hear from other people who are a bit like them. So clinicians like to hear from other clinicians, psychologists want to hear from other psychologists, right? Community members, artists want to hear from artists, and so on. So cultivating leadership and those clinical and other champions and supporting them to take leadership and be the icebreakers is a big part of helping to do the influencing.
Yeah, I was supposed to say something that's very similar. Basically, go tell people around you about this, or what you just learned from us. And sometimes I also like to think is that, I may be like a psychological expert on happiness, well-being, but I always like to say that you are an expert of, your loved one's happiness. Go do one nice thing for, your loved one after this talk, and everyone will be a little happy.
Good advice. We just have a couple of minutes left, and I thought maybe a good way to end off is maybe we can start with Dr. Block, and you can just offer your parting words for the audience.
Now you have to go from there.
What they said. Yeah, again, I just can't emphasize enough that like this work starts from the ability to engage with real people's lives, real people's stories, just hearing where people are at and what people tell us they need to improve their health. And that to me sits at the foundation really of all the work that I do.
I'll say that there's no shortage of capacity to do this work. We have what we need to make this happen. Yes, more investment would be nice, right, in research or in policy or in practice. But we have almost all the ingredients. We just haven't mixed them together with these priorities and in this way and built these relationships. And when we ask people what matters to them, that helps enliven it, makes it meaningful for us, it makes us hungry to come back for more. Everything from asking older adults in Timiskaming what they needed to get out there in the community, what they needed was pets to really feel strong to leave their homes, or another person who needed a fishing rod and a fishing buddy. Some of this stuff is really simple, but we would never think of it if we didn't just ask. So really centering, asking, and helping to each other to act on the answers, starting with what's strong, will get us a really long way.
Yeah, something I find extremely fortunate doing this line of work is that, I share with you how we measure happiness quantitatively, but another thing that we love to do is just go around asking people, what is your best possible life? That's your top anchor, right? Like, this is such a nice way for me to get to know my students, my colleagues and everyone. I felt like compared to social prescribing, the idea that, well-being should be the center of all policy, maybe it's still at a stage where we're building more awareness at this stage. Again, just having this conversation about asking people, what is your best possible life? What can we do about that? I feel like it's the most empowering way of thinking about public policy. Because it's no longer the government to tell you what your good life is. But lifestyle such as fundamentally about centering what the good life is and giving the power back to our citizens, our Canadians, so that public policy can now be realigned with what truly matters for Canadians.
Excellent. Okay, well, I'd just like to thank the panel for their wonderful thoughts and on this subject. To think about in terms of our Healthy Waterloo initiative, and we invite the audience to get involved in that initiative in some way. I know that this is something that the Faculty of Health is very determined to advance in not only in the community of our university, but also the larger community. So we really thank you for coming tonight and to listening to this wonderful panel. Thanks for being here.